My name's Catherine Baines. I'm a nurse practitioner that's spent the majority of my career in cardiology practice, and I've been involved with intervention and heart failure and have a sprinkling of electrophysiology in there. And so I'm very pleased to be able to be here today and to present on rhythm and EKG abnormalities caused by drugs and clinical conditions. So let's get started. Okay. So I have no current, I'm exiting out of some stuff. I have no current affiliations or financial arrangements with grantors or commercial interests that have a direct impact on this presentation. So our objectives today are to list the 5 different drug-induced EKG rhythm changes, specific rhythm changes, type of changes, describe the QT interval and the clinical implications associated with QT prolongation, discuss the risks and implications associated with pharmacological therapy in the cardiovascular patient. So the assessment of drug-induced changes in cardiac electrical activity remains a key component in the development of safe pharmacotherapeutic agents. Prior efforts to evaluate cardiac safety have focused primarily on the QT interval and the associated and potentially lethal ventricular arrhythmias. In view of the high risk for QTc prolongation and torsades with various drugs, it has now become a common practice for pharmaceutical and biotech companies to screen compounds for QTc prolongation activity during preclinical safety assessment. In addition, there is now an emerging and increasing awareness of drug effects on cardiac conduction that impact the PR and the QRS intervals. So that being said, there are only certain types of EKG abnormalities that are associated with medications and or clinical conditions that mimic those changes due to medications. These specific EKG changes are highlighted in red. They are abnormal intervals, specifically prolongation, abnormal waveforms, various heart blocks, atrial and ventricular rhythm disorders, metabolic abnormalities, and specific drug-induced changes such as DIG toxicity. The structural changes listed here are those associated with ischemia, infarction, enlargement, hypertrophy, etc., and they will not be a part of our discussion, but they are also obviously abnormalities diagnosed on EKG. The American Heart Association, in conjunction with the American College of Cardiology and the Heart Rhythm Society, have published scientific statements of specific recommendations to standardize for the interpretation of the EKG in order to provide uniformity of an EKG diagnosis. The primary diagnostic criteria have been organized into 14 categories, which are listed on this slide and the next slide. The 117 identified diagnoses that can be diagnosed on an EKG are subsequently placed in one of these 14 categories. For instance, the category of overall interpretation includes the diagnosis of normal EKG, otherwise normal EKG, abnormal EKG, and uninterpretable EKG. The category of technical conditions includes the diagnoses of various lead reversals or misplacement, missing leads, or artifact. And then for another example, the category of sinus node rhythm includes the diagnoses of sinus rhythm, sinus tach, sinus arrhythmia, etc. So the majority of these 14 categories and the 117 diagnoses that fall within these categories are non-descriptive, and they convey clinical meaning without additional statements. So those in red are the primary diagnostic criteria categories that would have the diagnoses associated with pharmacotherapy or a mimicking type of clinical condition. So on this slide, that would be, again, they're in red, the categories of ventricular arrhythmias, which would include the diagnosis of PVCs, the category of ventricular tachyarrhythmias, which would include the diagnosis of ventricular tachycardia. So listed here are the remaining 7 of the 14 categories for the primary diagnostic criteria of EKGs. Again, the items in red are the categories that would have the specific diagnosis that occur with specific types of pharmacotherapy and clinical conditions. So on this slide, these categories include atrioventricular conduction, intraventricular and intraatrial conduction, and ST segment, T wave, and U wave diagnoses. So let me clarify here that there are obviously many non-cardiac clinical conditions that can be diagnosed or suggested by EKG changes or abnormalities. But what I'm referring to in this discussion is specifically to EKG abnormalities that could also be caused by a primary type of pathology. So again, the American Heart Association, in conjunction with the American College of Cardiology and the Heart Rhythm Society, have also categorized a list of secondary diagnostic criteria, which provides additional distinction that can be used to expand on the specificity and clinical relevance of a particular diagnosis. So these secondary statements are divided into 2 groups: those that suggest a clinical diagnosis and those where a clinical diagnosis should be considered. So those preceded by the word suggest invoke a clinical diagnosis that's likely responsible for what is observed on the EKG. Again, in red are the types of EKG changes among these secondary diagnostic criteria that could be the result of certain types of pharmacotherapy or clinical condition. So the additional secondary diagnostic criteria that suggest include hyperkalemia, hypocalcemia, and hypokalemia, or a drug effect. So it would look something like this. The primary diagnosis might be abnormal EKG, suggests hyperkalemia. So that's the primary diagnosis with the secondary diagnostic criteria. The other category in the secondary diagnostic criteria is where a diagnosis might be preceded by the word consider. This is intended to propose at least one or potentially more than one clinical disorder that might be relevant to consider when specific EKG abnormalities are noted. So for our discussion on EKG changes due to medications or clinical condition, the EKG might state sinus bradycardia, consider hypothyroidism. Again, this clinical condition can be caused by both pharmacotherapy or a primary pathology. So on this slide are the remaining types of secondary diagnostic criteria that could be stated as considered with certain types of EKG changes. As you can see on this slide, none of them are in red, so therefore they'll not be a part of this discussion, but I wanted to include them so you would have a complete list of the secondary diagnostic criteria. In addition to the primary and secondary diagnostic criteria, the American Heart Association, American College of Cardiology, and Heart Rhythm Society have included other tertiary modifiers such as borderline, occasional, or prominent, as well as comparison statements between EKGs from the same patient that would include something such as new conduction abnormality or significant repolarization change. So that kind of gives you an idea of the terminology that is actually very specific when it comes to reading, interpreting, and diagnosing what is seen on the EKG. So these additional modifiers are intended to refine meaning and convey clinically important information while at the same time preserving brevity and uniformity. In addition to the specific diagnostic criteria we've discussed, the EKG can also reflect changes associated specifically with a primary or secondary myocardial process, such as coronary artery disease, hypertension, cardiomyopathy, or an infiltrative disorder. The EKG changes associated with these conditions, of course, are not the result of pharmacotherapy. However, metabolic abnormalities, as previously mentioned, and electrolyte abnormalities and both therapeutic or toxic effect of drugs can be the result of pharmacotherapy or a clinical condition. So any of these statements you potentially could see as part of the diagnosis on the EKG interpretation. Other clinical uses for the 12-lead EKG can also be associated with identification of hereditary or congenital long QT syndrome for which at least 7 genotypes are now known. So because we are more aware of the genotypes now, we are seeing more and more people that have the specific genetics to develop long QT syndrome. So in summary, there are dozens of primary and secondary diagnostic criteria, of which only certain ones are associated with either the therapeutic or adverse effect of pharmacological agents, as well as specific clinical conditions that can be identified or suggested by the EKG. So now we'll move into the specific types of EKG abnormalities and the drugs or clinical conditions that can cause these type of changes. This table shows the rate and rhythm conditions that might be the result of either medications or a clinical condition. So in other words, you can have underlying primary sinus bradycardia, but you can also have sinus bradycardia that's secondary to taking beta blockers, calcium channel blockers, DIG, or antiarrhythmics, as well as the clinical condition of hyperkalemia. So each of these have the potential to produce sinus bradycardia. The next column is sinus tachycardia, which can be caused by catecholamines, such as albuterol, as well as caffeine and phetamines, and the clinical condition of hyperthyroidism, which could be due either to too much thyroid supplementation or as a primary clinical condition. In the third column, heart block can be caused by the same agents and conditions as those associated with sinus bradycardia, as well as just deterioration of the conduction system. So people obviously can have an underlying heart block without any of these medications or clinical conditions. AFib can be the result of hyperthyroidism. Therefore, any workup for AFib should always include ruling out hyperthyroidism, either medically induced or as a primary clinical condition. And then in the last column, we have VT or VF. So by virtue of the pharmacokinetics, most antiarrhythmics, particularly the Vaughan Williams class 1 antiarrhythmics, have the potential to cause VT or VF. The ones you might see patients on in the outpatient setting include quinidine, disopyramide, mexiletine, flecainide, and propafenone. And as you all are aware, VT or VF can also occur as the result of the other medications and or clinical conditions listed in that last column. So this table shows the waveform abnormalities that might be the result of medications or clinical conditions. The AV nodal conduction abnormalities include ER interval prolongation and AV block, and can be the result of the specific classes of drugs listed in the first column, such as antiarrhythmics or the drugs used to treat specific conditions, such as viral infections, nausea in patients receiving chemotherapy, multiple sclerosis, partial onset seizures, or neuropathic pain. So then the ventricular conduction abnormalities in the second column are the result of changes in the QRS interval. And these also can be affected by antiarrhythmics as well as the antiemetic dolasetron. ST and T wave abnormalities are associated pretty much specifically with electrolyte disturbances as well as the effect of digoxin. So a complete patient history, updates and changes in medications, as well as familiarity with the impact of these particular medications is critical to preventing adverse outcomes. So let's have a quick review of pharmacodynamics and pharmacokinetics. As we all know, pharmacodynamics is the biochemical and physical or physiological effect of drugs and their mechanism of action. In other words, it's how the drug affects the body. Pharmacokinetics is the process associated with the absorption, distribution, biotransformation, metabolism, and excretion of medications. What I want to draw your attention to is the fact that both pharmacodynamic and pharmacokinetic drug interactions play a role in altering the EKG. For instance, sinus bradycardia due to the use of beta blockers is an example of the pharmacodynamic effect. The drug is doing what it was designed to do. It's important to remember also that both pharmacodynamic and pharmacokinetic drug interactions can also significantly increase the risk of QTC prolongation. So let's dig a little bit into the CYP450 system, as we know that this has a tremendous impact on drug metabolism. So the CYP450 enzyme system is one of several metabolic systems which enable organisms to deal with lipid-soluble environmental chemicals. The CYP450 enzymes are membrane-bound proteins, mostly found either in the endoplasmic reticulum or the inner membrane of the mitochondria. The CYP450 system oxidizes, hydrolyzes, and reduces chemicals for clearance from the body. The human genome comprises 57 functional protein-coding CYP450 genes that are grouped according to their sequence homology into 18 families and 44 subfamilies with subsequent subgrouping according to their biochemical relatedness. More than 30 distinguishable CYP450 enzymes have been described. They are found in the highest concentration in the liver, and in the case of certain subfamilies, in the small intestinal mucosa and other organs. Among these, the CYP enzymes of the families 1, 2, 3, and 4 are the ones mainly responsible for the metabolism of drugs. And of these families, the CYP450 enzymes that are the most important in drug metabolism are CYP1A2, CYP2C, the whole family of CYP2C, CYP2D6, and CYP3A4. The CYP enzyme families are designated by a digit after the CYP, with the individual families having in common a 40% homology in the amino acid sequence of the enzyme. CYP subfamilies are designated by a letter after the digit following CYP and are categorized by a 60% homology in the amino acid sequence of the enzyme. Then the last number in the name of an enzyme represents the sequence of discovery. Excuse me. So in other words, CYP3A4 is a cytochrome P450 enzyme that belongs to family 3 and subfamily A, and it was the fourth enzyme discovered with these specific homologies for family and subfamily. Excuse me. It's now established that variations in the genes for CYP450 enzymes is what contributes to the inter-individual differences in serum concentration of drug substrates and the associated interpatient variability. In addition, several CYP drug metabolizing enzymes are controlled by more than one variant gene, which further explains the differences in efficacy, toxicity, tolerance, and metabolism between individuals. So it's important to keep in mind when considering drug-to-drug interactions associated with changes on the EKG, particularly those associated with QT prolongation, because they're going to be specific to the patient based on their genetic makeup. So as we know, the CYP450 enzymes can potentially induce or inhibit the metabolism of the drug in question, with inducers accelerating metabolism, thus reducing efficacy, and inhibitors reducing metabolism, which may lead to increased efficacy or toxicity. So the way I remember it is that inducers reduce effectiveness and inhibitors increase efficacy and the potential for toxicity. So the effects on CYP enzyme activity are a major source of adverse drug interactions, and these type of interactions are particularly important when the drugs are of vital importance to the patient for a specific condition, or they have specific side effects, or they have a narrow therapeutic index, because we have to take into consideration the benefit to the patient versus the risk for adverse effects and drug-to-drug interactions due to the CYP450 system. So now let's have a little bit of a wave review. The P wave on the EKG is the representation of sequential right and left atrial activation or depolarization. The PR interval, as you can see here, is measured from the earliest point of the P wave onset to the earliest point onset of the QRS complex. The PR interval includes both atrial depolarization as well as the time for conduction to travel through the AV node the his, Purkinje, and bundle branches, then finally terminating at the onset of ventricular muscle depolarization and the beginning of the QRS. So delay in atrial activation and conduction through the AV node or conduction through the his, Purkinje system contributes to PR interval prolongation. Consequently, drugs that affect atrial activity may change P wave morphology or prolong the PR interval. So normal PR interval is 1200 to 200 milliseconds, and drugs that have an impact on the P wave and PR interval are going to be those listed on slides 12 under the columns of sinus bradycardia, heart block, and under the column of AV nodal conduction on slide 13. So now let's talk about various heart blocks that can occur within the conduction system. Heart block can be conceptualized in terms of two cardiac regions where heart block can occur, then further categorized by the 3 degrees of conduction failure. So the two primary regions of heart block include the SA node and the AV junction, which incorporates into it the AV node, the his bundle, as well as the bundle branches and their fascicles. The 3 degrees of heart block are 1st degree or slowed conduction, 2nd degree or intermittent conduction, and 3rd degree or complete conduction failure between the atria and the ventricles. In addition, there are 2 variants of 2nd degree heart block. Type 1 or Winky block is a decremental conduction from the SA node that progressively slows beat by beat until failure of conduction to the AV node occurs. This is a form of conduction block that occurs in the calcium channels of the AV node. Type 2 or Mobitz is when there's an intermittent failure of conduction between the SA and the AV node. This is more likely to occur in the sodium channels of the his bundle or in the bundle branches and fascicles. So with Winky block, you see that decremental prolongation of the PR interval until the beat is completely dropped. And with Mobitz, you might see conduction, conduction, no conduction, 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 no conduction. But the PR interval remains the same. The term exit block is a special term used to identify a conduction delay or failure that's immediately distal to a pacemaker site like the SA node. So again, the drugs listed in those specific columns on slide 12 and 13 are the ones that would have an impact in this particular area or cause these types of changes on the EKG. So here's an example of 1st degree block where the PR interval is prolonged to 280 milliseconds, but there's consistent conduction to the ventricles. In other words, there's a P wave for every QRS. So that's just a good example. Then this is an example of an SA exit block. And so remember, the exit block is a special term used to identify a conduction delay or failure that's immediately distal to a pacemaker site, such as the SA node. So on this rhythm strip, the red arrows are pointing to where the SA node is firing, and the P wave gradually gets further and further away. So there's a block between the SA node and the actual conduction through the atria. So note how the PR interval does not get incrementally longer as in type 1 2nd degree AV block, but the distance between where the red arrow shows the SA node is firing and where the PR interval is, or the PR wave is, does get longer. So just kind of an interesting rhythm strip you don't see very often. So as mentioned previously, 1st degree AV block characterizes the delay or slowing of conduction from the SA node to the AV node and is manifested as PR interval prolongation, typically greater than 200 milliseconds. Now this has to be under the condition of sinus rhythm with normal heart rates between 60 and 100. So the presence of intermittent 1st degree AV block as well as type 1 2nd degree AV block or Winky block, as opposed to the persistent presence of these conditions, does not necessarily indicate an underlying pathological condition and may actually be related to normal physiological variations. Although these lower degrees of AV block are often not clinically concerning, if they are drug-induced, they may be indicative of more significant AV conduction problems. Hence, drug-induced PR interval prolongation and AV block are often viewed as potentially deleterious. It gives us the idea, or it suggests to us that When the patient's not on that medication, the PR interval is normal, or there's not a block of any kind, but once they're on the medication, it shouldn't cause those changes. So it suggests that there's something wrong with the conduction system underlying. So as we know, clinical condition of patients can change. So for instance, a beta blocker or a calcium channel blocker that was therapeutic at a specific dose in a 60-year-old 10 years ago might induce bradycardia or AV block in that same patient at the age of 70 due to a gradual age-related fibrosis and slowing of the conduction system. So this actually happened to my mother. We had to change her dose on her calcium channel blocker, as well as her beta blocker. And so this is just something that we just need to be aware of. And again, it suggests underlying conduction problems if we have to begin to make those kinds of changes, something that we just need to keep an eye on. So here's where we need to begin to draw a distinction and recognize the nuances that might have clinical relevance. So first-degree AV block has long been thought to be a benign prognosis that's based primarily on observations from two large and older studies, one that was done in 1959 and another one that was done in 1982 that evaluated about 5,000 healthy subjects. A subsequent investigative study in 1984 of about 1,800 middle-aged men without known heart disease suggested that PR prolongation at baseline often normalized at follow-up several years later, and that progression to high-grade AV block over that time was rare. However, an analysis done in 2009 of 7,500 participants in the Framingham Heart Study, which included older individuals and those with medical comorbidities, reported that prolongation of the PR interval was associated with increased risk for pacemaker implantation, development of atrial fibrillation, as well as all-cause mortality. So it's important to keep in mind that these findings can suggest that the earlier data on the natural history of PR prolongation in healthy individuals may not be representative of the prognosis of PR prolongation in older populations of patients, particularly those with concomitant illnesses such as coronary artery disease. So another study in 2011 showed that PR interval prolongation was associated with a higher risk for congestive heart failure and death in patients that had stable coronary artery disease. So these population studies suggest that elderly patients may be at higher risk for complications from drugs that affect AV conduction. So the take-home message is keep an eye on your elderly patients that are on drugs that can cause bradycardia, PR interval prolongation, and AV conduction delay, as they may develop other conditions that could potentiate the adverse reactions to drugs that were previously safe for them to be on. So moving on from first-degree AV block to type 1 second-degree AV block, Winky block. So we know that Winky block with a narrow or normal QRS complex is observed in up to 1% of healthy young subjects, especially during sleep. However, again, in the older patient, this might warrant further evaluation of the rhythm. For patients that are on drugs that can cause PR interval prolongation and AV block, if AV conduction delay occurs, it usually resolves after dose adjustment or discontinuation. In patients that are suspect, it's important to assess for symptoms associated with bradycardia or pauses such as fatigue, dizziness, or syncope, particularly in that older population, because there's so many things that can make them fatigued and there's so many things that can make them dizzy. So we just need to have them be aware that it can be due to changes in their conduction system, or it might even be due to the medications that they're on. The higher degree type 2 second degree AV block, or MOBITS, is generally considered to be pathological and usually involves infranodal block and structural cardiac abnormalities. This condition carries an increased risk for progression on to third degree or complete AV block. So we've discussed PR interval prolongation and AV block. Now let's move on to QRS interval prolongation. So the normal QRS represents the almost simultaneous activation or depolarization of both the right and left ventricles, although most of the waveform is derived from the larger left ventricle. The QRS duration is measured from the earliest Q or R wave onset to the latest S wave offset. And the width of the QRS complex is the duration of the ventricular muscle depolarization and is generally measured at anywhere from 60 to 110 milliseconds. The STT wave reflects ventricular repolarization, and the U wave reflects a small after depolarization event at the beginning of diastole. So QRS prolongation may result from a wide range of conditions involving the myocardium, such as diffuse processes of hypertrophic or infiltrative disease, or focal damage from infarction, which can lead to disturbances within the conduction system. So again, I refer you back to slide 12 and 13 so that you can see the drugs and clinical conditions that might fall into those categories. In addition to conduction being affected by diffuse or focal conditions, slowed conduction or electrical impulses can be caused by conduction system disease alone. Since all cardiac tissue has the ability to propagate electrical conduction, there can also be slowed propagation of the impulse that can occur outside the conduction system through the intraventricular myocardium. This is described as nonspecific intraventricular conduction delay. So again, if a patient has something like this, then it suggests that there is already some type of conduction problem, which also can be exacerbated by medications. So in summary, QRS prolongation and the subsequent conduction delay can be the result of underlying myocardial diffuse or focal pathology, which can lead to reduced intramyocardial conduction velocity and the intraventricular conduction delay. So when conduction system dysfunction influences the QRS duration, the QRS complex typically assumes a distinctive morphology such as that we see with left bundle branch block, right bundle branch block, left anterior and left posterior fascicular block, as well as the intraventricular conduction delay. In a modest percentage of patients or of the population, right bundle branch block may actually be functional and can carry a benign prognosis. But right bundle branch block can also be a sign of underlying heart disease with a poor prognosis. However, left bundle branch block is always pathological, and if new, the patient should always undergo, with a measure of urgency, a complete workup for coronary artery disease. Pathological causes of left bundle branch block include ischemic heart disease, hypertrophy, endocarditis, myocarditis, cardiomyopathy, congenital defects, and age-dependent degenerative changes. So when associated with conduction system disease, QRS interval prolongation may herald an increasing risk of progression to clinically significant AV block. So a prospective study in the early to mid-2000s suggested that an increased QRS duration independently predicted the risk of sudden cardiac death, with a 2.5-fold elevated risk in subjects with a QRS greater than 110 milliseconds compared to those with a QRS of less than 96 milliseconds. And that's particularly interesting because these were not necessarily people that had coronary artery disease or any type of cardiac abnormality. It was just simply the QRS duration. In the presence of cardiovascular disease, QRS prolongation may reflect underlying pathophysiological changes that may be proarrhythmic, with the resultant mechanical dysynchrony that can potentially worsen ventricular function. So here's some of the conditions that have a poor prognosis when seen in the setting of QRS prolongation. For hypertensive patients who have persistent QRS prolongation while on medication, there's a higher incidence of subsequent heart failure when compared to hypertensive patients on medication with a normal QRS interval duration. In heart failure, QRS prolongation in the form of intraventricular conduction delay or left bundle branch block, to a greater extent than right bundle branch block, carries an increased risk of worsening heart failure and death. These are the patients, the ones specifically with left bundle branch block, that receive a biventricular pacemaker defibrillator versus a defibrillator alone when they've been diagnosed with heart failure. Also, in the presence of heart failure, increased QRS interval duration is associated with a progressively escalating propensity to develop atrial fibrillation. So these findings clearly show that the increased risk for adverse outcomes in patients with cardiovascular disease associated with the widening of the QRS and the increased risk for adverse drug effects superimposed in this milieu particularly for drugs with the potential to further prolong depolarization and widen the QRS. So just be aware when you see patients that have these type of EKG changes that given certain conditions, that can mean that they are at risk for adverse events. In summary, there's an increased risk for adverse events in patients with cardiovascular disease with a widening of the QRS complex. Subsequently, there's an increased risk for adverse drug effects superimposed on these conditions. What's not well established, though, is the risk associated with drug-induced QRS widening in other conditions or underlying substrates. We just don't have any information about that, so we don't really know if there's more risk with that or not. So what drugs do we need to be watching for these patients? So treatment with some von Williams class 1 antiarrhythmics, such as quinidine, flecainide, or propafenone, are commonly associated with QRS prolongation. These class 1 antiarrhythmics, again, this is a pharmacodynamic effect. They slow depolarization and reduce conduction velocity, thus prolonging the QRS interval. But the flip side of the coin is that's what also makes them somewhat pro-arrhythmic. Although these agents can be effective under certain conditions, they do have pro-arrhythmic effects, particularly in patients with structural heart disease. And many of these patients with structural heart disease actually have to be on antiarrhythmics. The key is to be aware that changes on the EKG may occur as a result of a subclinical deterioration of their condition or due to the medications they are on, which could produce an adverse reaction. So drug-induced QRS widening may be viewed as a potential marker for increased arrhythmogenicity, again, especially in the setting of heart disease because of its effect on the QT interval. So it's just a good idea to be aware of changes that are occurring on the patient's EKG when they're on these medications. Now let's look at QTC prolongation. So this is the area where drug-induced arrhythmias occur. The potential for patients to be on medications that can exacerbate or produce drug-induced arrhythmias is a problem faced by all providers that prescribe drugs and extends far beyond those that are in cardiology or electrophysiology practices. As the number of available drugs expands, the potential for patients to be on drugs that can potentiate proarrhythmias increases. The data shows, however, despite this potential for serious consequences, the level of awareness of the proarrhythmic potential of many drugs, particularly non-cardiac drugs, is either low or non-existent for most prescribing clinicians. So our goal then should be to maximize therapeutic potential of what we prescribe while minimizing proarrhythmic risk. So our understanding of drug-induced arrhythmias is actually quite recent. Historically, syncope related to the use of quinidine was not identified until the 1920s. But then it wasn't until the 1960s that the cause of this type of syncope was then understood. It was at that time that a drug-related, pause-dependent form of polymorphic VT was first identified and described. This potentially lethal ventricular arrhythmia was subsequently known as torsades. The work associating quinidine with syncope and torsades noted during treatment for chronic AFib was identified during this time frame as well. So in the following decades, arrhythmias related to non-cardiac medications, including antihistamines and antipsychotics, began to be reported. Ultimately, over the course of several more decades, the mechanism of QTC prolongation leading to torsades was elucidated and is now a major focus of drug development and regulatory oversight. So let's talk a little bit about this critical area of the cardiac cycle. The QT interval is the duration of both the ventricular depolarization as well as ventricular repolarization and is measured from the beginning of the QRS, thus including the QRS interval to the end of the T wave. The QT interval will often be corrected or recalculated based on heart rate as the QT interval becomes more narrow at higher heart rates. With regards to description, the QT interval is used. However, when discussing prolongation of the QT interval, it's generally referred to as the QTC or the corrected QT, as the corrected QT is the baseline for determining whether the interval is prolonged or not. There are multiple formulas for calculating the QTC. which have their own benefits and shortcomings. However, there's no consensus onto which one is actually the most accurate. However, the most universally adopted method is Bazette's formula, which provides an adequate correction for heart rates ranging from 60 to 100. However, Bazette's formula underestimates QT intervals at low rates and overestimates QT intervals at high rates, and thus cannot be used to calculate for correction of QT in heart rates less than 60 or more than 100. So because QT interval encompasses both depolarization and repolarization, the interval is lengthened by a widening of the QRS, which is why that previous discussion was important. So it actually takes specialized training to utilize Bazette's formula and make the determination as to whether the QTC is prolonged or not. What's important to keep in mind, though, is that the QTC that an EKG calculates is not always accurate. So I bring this point up to just highlight the fact that you might have a patient that's seen by electrophysiology who are going to be able to calculate the QTC and see references to prolongation that might not actually be noted on the EKG that you see in the chart. So there may be some discrepancy between those. So this is the table showing what is considered to be normal QTC, borderline QTC, and long QTC in both men and women. So as you can see, there's a gender difference that speaks to the slightly increased risk that women have for the arrhythmias associated with QTC prolongation. It's important to note that the risk of cardiac events correlates with the degree of QTC prolongation, with the most common ventricular arrhythmias, such as torsades, being associated with a QTC of greater than 500 milliseconds. QTC prolongation has important clinical implications, and of course this is a great example, since it usually indicates a state of increased vulnerability to malignant ventricular arrhythmias, syncope, and sudden death. So this is a great example of torsades. Torsades is the prototype arrhythmia of both congenital long QT syndrome as well as patients that have acquired QTC prolongation. According to Tabors, torsades de pointes is a polymorphic, rapid, unstable form of VT characterized by varying morphology and amplitude, which you can see there, of the QRS complexes, which appear to twist or shift in electrical orientation around the isoelectric line. The ion channels affected in both congenital, hereditary, and I can't remember the other term, long QT syndrome are the same channels that are affected when you have QTC prolongation that turns into torsades. So drug-induced QTC prolongation is a complicated phenomena related not just to drug properties or dose of a particular drug, but also to drug-drug interactions as well as non-pharmacological risk factors. Several drugs have been withdrawn from the US market or have received black box warnings due to their potential to cause QTC prolongation. So the point of this slide basically is to show you a good example of torsades, but to also highlight the point that the mechanism for both congenital or hereditary long QT syndrome is the same as the mechanism when someone develops QTC prolongation and deteriorates into torsades. So drug-induced QTC prolongation is unpredictable in any given individual, so predicting the risks involved with most of these drugs is difficult since they're often structurally and pharmacologically unrelated. However, a patient's risk of fatal ventricular arrhythmia may be reduced with greater awareness of the non-pharmacological risk factors, the drugs known to cause QTC prolongation, and specific drug interactions that can potentiate QTC prolongation or long QT syndrome. For example, in patients with a normal baseline QTC, amiodarone, which is an antiarrhythmic used to treat both atrial and ventricular arrhythmias, prolongs the QT interval but rarely causes torsades. So it appears that even with some drugs known to potentiate QTC prolongation, certain additional risk factors play a major role in facilitating the progression from QTC prolongation to drug-induced torsades. These various risk factors are individually specific and result in a lowering of the threshold for the development of QTC prolongation and the associated ventricular arrhythmias. For example, in one study, almost all patients who developed torsades had one risk factor and 71% had multiple risk factors. So screening patients for these risk factors is really important. Let's look at some of them. So risk factors such as LV failure, use of QTc prolonging drugs, and the presence of congenital long QT syndrome are counterintuitive. It's pretty obvious that those would be risk factors. However, some are not quite as straightforward. For instance, the female gender difference as a risk factor for QTc prolongation is not clearly understood, but it's thought that androgens somehow play a protective role in men. I think that's their way of saying they don't really know what the difference is. The presence of bradycardia prolongs the repolarization phase, which makes an individual with bradycardia more vulnerable to drug-induced QTc prolongation and thus potentially to torsades. Interaction between concomitant drugs can lead to a prolonged QTc if there's an additive or potentiating effect, such as with the CYP3A4 inhibitors, the azoles or the mycins or grapefruit juice, which will increase these drug levels. So here are the specific drug classes known to potentiate the drug-to-drug interactions that can result in a prolonged QTc or torsades. Remember, if we have patients on one or more drugs in these classes, it's important that we keep in mind those non-pharmacological risk factors on the previous slide, so we can truly weigh the risk-benefit ratio to determine if indeed the drugs we are selecting are the best. Complete and updated lists of drugs known to cause QTc prolongation and or torsades are available at these websites. Credible Meds is an online nonprofit resource that promotes the safe use of medicines. It was created and is maintained by the Arizona Center for Education and Research on Therapeutics, also known as AZERT. Their mission is to foster the safe use of medications. Credible Meds has a global recognition as a trusted resource on safe medication use for healthcare providers, research scientists, as well as the public. AZERT maintains the Credible Meds database and its many resources and is best known for the list of drugs that have a risk of QTc prolongation and cardiac arrhythmias. Under contract with the FDA's Safe Use Initiative, AZERT developed and launched hospital-based clinical decision support systems that are now being expanded for all clinical environments. And what I really like about the information that's provided here is it breaks down the risk in the medications based on observations in clinical trials to known risk of torsades. So these drugs prolong QT interval and are clearly associated with the risk of torsades. Possible risk of torsades, which it goes on to explain that. Conditional risk of torsades and explains the specifics around that, as well as drugs to avoid with congenital long QT. So I just think it's really helpful because when you look at specific drugs, it gives you that kind of risk profile and tells you what specific risk that medication has. And that can have implications with as it relates to your decision making. So this is a screenshot of the Credible Meds website, and I want to encourage you to get familiar with the site so you can look up the risks associated with the drugs you most frequently prescribe or drugs that some of your patients might be on that you are not familiar with. It's actually very user-friendly. So in conclusion, it's vital that we understand that a patient's clinical condition is not static and that over time their risk for drug-induced EKG changes can increase. Awareness of comorbidities such as heart disease, hypertension, and heart failure that can increase a patient's risk for significant EKG changes when prescribed certain medications can help us to prevent adverse reactions. Being familiar with the drugs that are known to cause any EKG change is also important. I think the other thing that's important is that, as I listed earlier, there are clinical conditions that can have a primary pathology, but can also be related to medications. And so it's important to keep those in mind as well, because when we see those, we need to explore those possibilities. Close monitoring is particularly necessary when QTc prolonging drugs are utilized, and exploring and documenting a family history of sudden cardiac death or congenital or acquired long QT syndrome should be done with all patients. Patients must be counseled about the potential risks associated with these medications and informed of the symptoms of arrhythmias, such as lightheadedness, dizziness, palpitations, shortness of breath, and syncope. Most patients would never connect these seemingly vague symptoms with a drug reaction, so we really have to educate them. Patients should be counseled to seek medical attention if these type of symptoms occur. Remember, these type of drug interactions are particularly significant when the drugs are of vital importance to the patient, have significant side effects, or have a narrow therapeutic index. And at that point, we must truly determine the risk-benefit ratio when prescribing. Although QTc prolongation has been linked to the use of certain drugs, it remains difficult to predict the relative risk associated with the administration. Nurse practitioners can help promote safe prescribing practices when selecting QTc prolonging drugs. Drugs that have QTc prolonging effects should not exceed recommended dosing range, as drug-induced arrhythmias are often a result of high drug concentrations. QTc prolonging medication should be prescribed with caution in patients who have underlying risk factors such as cardiac disorders or other non-pharmacological risk factors that could potentiate QTc prolongation. And we must assess and document the non-pharmacological risk factors patients might have when selecting a medication that has been associated with QTc prolongation. Again, educating patients on the risk associated with these drugs, the signs and symptoms associated with arrhythmias, and when to seek medical attention is an important part of our role as providers. Screening for potential drug interactions and electrolyte abnormalities may also help lead to safer therapies and potentially preventing the development of ventricular arrhythmias. So that's the conclusion of my presentation, and I'm happy to take any questions.